Assalamu alaikum. Now I would like to discuss about the poisoning regarding poisoning regarding respiratory system. Okay. Auzu billahi minash shaitanir rajim. Bismillahir rahmanir rahim. Rabbi zidni ilma, Rabbi zidni ilma, Rabbi zidni. First of all, this one, cyanide poisoning. The most common etiology of this cyanide poisoning is due to combustion of the plastic, is due to occupational uh, exposure like mining, and the last but not the least is due to cyanide containing medication like antihypertensive drug like sodium nitroprusside. Sodium nitroprusside is an antihypertensive drug used in where can you tell me? Used in hypertensive hypertensive urgency. So structural fire like combustion of plastics, mining, mining, and the cyanide containing medication can cause this cyanide poisoning. Pathophysiology. It inhibits oxidative phosphorylation and forces anaerobic metabolism. So it inhibits oxidative phosphorylation and forces anaerobic metabolism and rapidly lethal if untreated. It is rapidly lethal if untreated. Clinical feature is hypertension, tachycardia, tachypnea, and circulatory collapse and death. Hypertension, tachycardia, tachypnea, circulatory collapse and death. And clinical feature there is headache, confusion, anxiety, seizure, coma, and there is shaded skin and elevated anion gap metabolic acidosis with increased lactic acid. Cyanide poisoning is in here. There is hypertension, tachycardia, tachypnea, circulatory collapse and death, headache, confusion, anxiety may happen, and in here you will get cherry red skin, elevated anion gap metabolic acidosis with increased lactic acid. Elevated anion gap metabolic acidosis with increased lactic acid. Management is decontamination, supportive care, 100% oxygen, IV fluid and vasopressin. 100% oxygen, IV fluid and vasopressin. Empiric treatment with hydroxycobalamin and sodium thiosulfate. This is the empiric treatment. Hydroxycobalamin and sodium thiosulfate. It is actually used in cyanide poisoning empirically. If you suspect a case of cyanide poisoning, like if there is a structural fire, if there is a history of taking cyanide containing medication, then you can empirically give it. And sodium nitrite, sodium thiosulfate is an alternative treatment but is contraindicated. These two, sodium nitrate and sodium thiosulfate, is contraindicated in carbon monoxide poisoning. So very high yield to differentiate these cyanide and carbon monoxide poisoning. First of all, I will discuss these two topics. Try to then I will try to make the differentiate. I'll try to make the differentiate of these. Again, the cyanide poisoning. What are the manifestations? In skin, there is flushing, cherry red color skin. There may be cyanosis. Initially, flushing, red color, then cyanosis. Central nervous system like headache, altered mental status, seizures, coma, and cardiovascular like arrhythmia, and in respiratory there is tachypnea, followed by the respiratory depression and pulmonary edema. So respiratory tachypnea followed by respiratory depression and pulmonary edema, and gastrointestinal is abdominal pain, nausea, and vomiting. Renal is metabolic acidosis. There may be lactic acidosis, renal is metabolic acidosis, lactic acidosis, and renal failure. So in skin, there may be flushing, cyanosis, and central nervous system like headache, altered mental status, seizures, coma, cardiovascular is arrhythmia, respiratory is tachypnea followed by respiratory depression, GI is abdominal pain, nausea, vomiting, and renal is metabolic acidosis. Common etiology is a combustion of the carbon and nitrogen compounds like wool, silk. This combustion can cause this and industrial exposure, metal extraction in mining. In mining, where the metal extraction can enter into the lungs and can cause this type of thing. And medication, sodium nitroprusside. Cyanide is a potent inhibitor of cytochrome oxidase A3. Cyanide is a potent inhibitor of cytochrome oxidase A3 in the mitochondrial electron transport chain. It binds to the ferric it binds to the ferric iron, inhibiting its reduction to the ferrous iron and blocking production of ATP from oxidative phosphorylation. Cells then switch to anaerobic metabolism, leading to lactic acid formation and causing metabolic acidosis. Sodium bicarbonate levels fall in an attempt to buffer uh, these excess acid. Metabolic acidosis also triggers central and peripheral chemoreceptor, resulting in increased alveolar ventilation and thus presenting tachypnea. So lactic acid accumulation causing lactic acidosis or metabolic acidosis. To compensate, to buffer this excess acid, bicarbonate level falls, and metabolic acidosis also triggers the central and peripheral chemoreceptor, increase alveolar ventilation, and then presenting tachypnea. These leads to fall in the arterial PCO2 or PaCO2. Patients with cyanide poisoning are markedly elevated lactate level. So in cyanide poisoning, one thing I have found that elevated lactate level more than 10 milliequivalent will found cyanide poisoning. There is elevated lactate level. Cyanide toxicity can occur in patients treated with nitroprusside who receive prolonged infusions, higher doses, or underlying renal insufficiency. It presents with altered mental status, lactic acidosis, seizures, and coma. Sodium nitroprusside is a potent arterial or venous dilator. Cyanide toxicity. Cyanide toxicity can occur in patients treated with nitroprusside who receive prolonged infusion one higher doses and have underlying renal insufficiency. These three things should be in consideration. Prolonged infusion, higher doses, and a renal insufficiency. It presents with altered mental status, lactic acidosis, seizure, and coma. Sodium nitroprusside is a potent arterial and venous vasodilator, often used for hypertensive emergency. Prolonged infusion more than 24 hours at a high rate, 5 to 10 microgram per kg per minute, can lead to cyanotoxicity. More than 24 hours and 5 to 10 microgram per kg per minute can lead to cyanide toxicity, especially in a patient with CKDs. As there is a low infusion rate, less than 2 short-term close monitoring are recommended. Treatment includes sodium thiosulfate. Cyanide toxicity is a must know. So, when cyanide toxicity may happen, if a patient have hypertensive emergency and we are giving cyanide to control the hypertension because it is a very good drug, but you have to consider three things. You should not give prolonged infusion like more than 24 hours, should not give more than 24 hours, should be given a stable rate, low rate, not in higher rate like 5 to 10 microgram per kg per minute. If you give at high rate, this may cause, and if there is renal insufficiency, these three things can cause cyanide toxicity. Treatment overview of the suspected cyanide poisoning: dermal exposure, removal of clothing, skin decontamination, ingestion, activated charcoal, all exposure, antidote. Dermal exposure should remove clothing, ingestion. If cyanide is ingested, and give activated charcoal. Antidote, hydroxycobalamin is preferred. Sodium thiosulfate as an alternative therapy and antidote not available. Antidote not available. Nitrite to induce methemoglobin. If antidote is not available, give nitrite to induce methemoglobinemia. To induce methemoglobinemia. And the respiratory support, mouth to mouth resuscitation, uh, supplemental oxygen, airway protection should be done, and cardiovascular support like IV fluid for hypertension should be given. Hypofluid for hypertension should be given. Now, carbon monoxide poisoning, CO, carbon monoxide. Smoke inhalation, defective heating system, smoke inhalation, defective heating system, gas motor operating, poorly ventilated area may cause these carbon monoxide poisoning. Mild to moderate is headache and confusion, malaise, dizziness, nausea. In case of C is severe seizure, syncope, coma, and myocardial ischemia and arrhythmia may happen. If you do AVG, if you do AVG, carboxyhemoglobin level be should be take, taken in consideration in ECG, with or without cardiac enzyme, high flow 100% oxygen, and intubation hyperbaric oxygen. In intubation, severe carbon dioxide poisoning can cause cerebral hypoxia and lactic acidosis. Cerebral hypoxia is drowsiness, confusion, seizure, syncope, coma, and lactic acidosis, elevated lactate, impaired oxygen utilization, impaired oxygen utilization, and myocardial injury. Myocardial injury can occur due to severe carbon monoxide poison, ventricular arrhythmia, myocardial ischemia, ECG changes, hypertension, troponemia, hypertroponemia, even without obstructive coronary lesion, pulmonary edema, cardiac dysfunction, or carbon monoxide induced alveolar damage. Acute myocardial infarction is reported one-third of the patient with carbon monoxide poisoning and is associated with increased mortality. Bright cherry lips can be a sign of carbon monoxide poisoning and non-specific. The diagnosis is confirmed clinically and by documenting an elevated carboxyhemoglobin level, even mm, more than 3% in non-smoker and more than 10% in smoker, more than 3% in non-smoker and more than 10% in smoker. So you have to look for carboxyhemoglobin level. Carbon monoxide is a byproduct of a combustion of the organic matter oil, gas, wood. Carbon monoxide is tasteless, colorless, and odorless gas produced by incomplete combustion of the carbon containing compounds. Non-smokers have low level less than 3 grams of carboxyhemoglobin due to normal enzymatic reaction, and cigarette a smoker may have carboxyhemoglobin level at a high rate. So chronic carbon monoxide toxicity chronic is a cause of secondary polycythemia. Pulse oximetry does not differentiate the carboxyhemoglobin level and oxyhemoglobin level be used because it cannot be used in diagnosing because it cannot be used in the diagnosis of the carbon monoxide poisoning. Diagnosis is made by ABG, arterial blood gas with co-oximetry. Arterial blood gas with co-oximetry. Carbon monoxide causes toxicity by impairing oxygen delivery and uses in three ways. Carbon monoxide binds with hemoglobin in greater affinity than oxygen, causing a large reduction in oxygen carrying capacity. Carbon monoxide causes a left shift of the hemoglobin decision curve, decreasing oxygen unloading, and carbon monoxide disrupt oxidative phosphorylation in mitochondria. These three ways can cause carbon monoxide toxicity. Lab result is HAGMA, that means high anion gap metabolic acidosis from peripheral tissue hypoxia. Persistent hypoxic brain injury can occur. An MRI showing bilateral hyperintensity of the globus pallidus. MRI may showing bilateral hyperintensity in the globus pallidus, an area highly sensitive to hypoxic condition. In this picture, you can see these effect bilateral hyperintensity. In this picture, you can see this bilateral hyperintensity of the globus pallidus. In here, there is bilateral hyperintensity of the globus. This is a bilateral hyperintensity of the globus pallidus. Pulse oximetry shows normal oxygen saturation because it cannot differentiate. Pulse oximetry cannot differentiate oxyhemoglobin and carboxyhemoglobin. Diagnosis is best confirmed by a co-oximetry of the arterial blood gas showing elevated carboxyhemoglobin level. The treatment of carbon monoxide poisoning involves administration of the 100% oxygen by NRV face masks to complete with carbon monoxide binding to hemoglobin and to decrease the half of the carbon monoxide from 5 hours on room air to 1 to 2 hours on 100% oxygen. Patients should be monitored for more than 4 hours and hospitalized if their condition has not improved. Hyperbaric oxygen is sometimes used in severe cases and that are unresponsive to face mask administered oxygen. This is the methemoglobinemia to exposure to oxidizing substance like dapsone nitrate, topical anesthetic. In methemoglobin, there may be cyanosis. Pulse oximetry is 85%. Dark chocolate color. Saturation gap is more than 5%. Difference of oxygen saturation on pulse oximetry and AVG. If there is saturation gap more than 5%, then means saturation gap and oxygen difference between oxygen saturation on pulse oximetry and AVG and normal PaO2. Pulse oximetry saturation is 85%, but AVG saturation is more. Then you should be taken in or ABG saturation is less, like if there is 5% difference of between oxygen saturation on pulse oximetry and ABG, diagnosis done. Some medication like dapsone used in leprosy, topical anesthetic like benzocaine and nitrate in infants causes and causes the iron component of the hemoglobin to be oxidized and thereby forming methemoglobin and cannot bind. Ferric acid is ferric acid. Ferric iron is unable to bind. In addition to ferric stage changes the hemoglobin structure and causes ferrocite to have increased affinity for oxygen. Left shift on oxygen hemoglobin distribution curve. The increased oxygen affinity prevents oxygen release. So we are trying to do what? We know that ferric iron is unable to bind to oxygen. In addition to ferric state changes, the hemoglobin structure causes ferrocite to have increased affinity. Was the increased affinity for oxygen. Because methemoglobinemia absorb light at a distant wavelength, pulse oximetry is 85% regardless of true oxygen saturation. In parallel, blood gas analysis frequently returns falsely elevated result for oxygen saturation like 99%. In blood gas there is 99%, but pulse oximetry is 85%. The difference between these, it provides an estimate based on the partial pressure of oxygen, not on effective hemoglobin saturation. These incorrect readings create a large oxygen saturation gap. Cyanosis can occur in methemoglobin comprises more than 10% of the 10% of total hemoglobin, but hypoxemia Headache and lethargy can occur when levels suppresses to 20%. At more than 50%, there is a risk of severe symptom or mental seizures. So 10% hemoglobin difference, 10% methhemoglobin comprises more than 10% of the total hemoglobin. 10% can cause hypoxic symptom, 20% can cause headache, lethargy, and 50% can cause severe altered mental seizure. Supplemental oxygen has no effect on the altered methemoglobin structure, and therefore it should not be. It doesn't improve cyanosis. Blood color, pulse oximeter reading, in contrast, arterial blood gas testing analyzes only unbound oxygen and displays falsely elevated oxygen saturation and frozen. Normal PO2 treatment involves discontinuing the causative agent and discontinuing the methylene blue acts as an electron transporter for NADPH and is reduced to leukomethylene blue, which turns to reduce methemoglobinemia, which in turn reduces to methemoglobin to hemoglobin. High dose ascorbic acid vitamin C acts as a reducing agent, can be used when methylene blue is unavailable and or contraindicated in glucose 6 phosphate dehydrogenase deficiency. In glucose 6 phosphate dehydrogenase deficiency, if methylene blue is not present, you can give high dose ascorbic acid. Okay, last thing, the difference between cyanide and carbon monoxide poisoning. Cyanide, we know that synthetic product combustion amygdalin found in apricot seed, cyanide ingestion in suicide attempt, fire victim can cause cyanide, and carbon monoxide combustion of gas heater, fire victim. Presentation, headache, dyspnea, cyanide causing headache, dyspnea, drowsiness, seizure, coma. Skin appear flushed, cherry red, venules in the retina bright red. In here, carbon monoxide, there is headache, vomiting, confusion, visual problem. May have cherry skin with bullous skin. Multiple victim may be involved. Other members of the family. In cyanide poisoning, breath may have bitter almond odor. Cyanide poisoning, normal PO2. In carbon monoxide, normal PO2. In cyanide, elevated lactate, higher metabolic acidosis. In carbon monoxide, elevated carboxyhemoglobin on co-oximetry classically associated with bilateral globus pallidus. Carbon monoxide bilateral globus pallidus lesion, bilateral globus pallidus lesion on MRI. There is hyperintensity in the bilateral globus. In cyanide poison, oxygen hemoglobin. In cyanide, oxygen hemoglobin decision curve normal. In carbon monoxide poisoning, left shift. Cyanide decontamination, removable clothing, hydroxychlorolamine, which binds cyanide to form cyanocobalamin, and renal toxication. Nitrite, which oxidizes with hemoglobin and form methemoglobin and binds cyanide. Cyanomethyl decrease oxygen, sodium thiosulfate, increase cyanide conversion to thiocyanate. Carbon monoxide poisoning, 100% oxygen and hyperbaric oxygen should be given. And that's all about the respiratory poisoning. Hope you enjoyed.